Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JACO podcast provides observations and commentary on the JACO article, Overall and Cancer-Specific Survival of Breast, Colon, Kidney, and Lung Cancer in Patients with and Without Chronic Lymphocytic Leukemia, a SEER population-based study of over 2 million patients by Benjamin, Solomon, and colleagues. My name is Lois Travis, and I'm the Director of the Rubin Center for Cancer Survivorship and Professor-in-Chief of the Division of Cancer Survivorship in the Department of Radiation Oncology at the University of Rochester's James P. Wilmot Cancer Center in Rochester, New York, United States. My specialties are clinical pathology and epidemiology. There are now about 13.7 million cancer survivors in the U.S., representing 4% of the population. The number of survivors continues to grow at an estimated rate of about 2% per year. Thus, an increasing number of individuals in the U.S. are now either cured of cancer or are living with cancer and remain at risk of developing a second malignant neoplasm. In fact, second or higher order cancers now represent about 1 in 5 of all new cancers reported to the population-based SEER program. These second cancers are not necessarily a reflection of antecedent cancer treatment, but can also represent the effects of shared etiologic factors, for example, tobacco and excessive alcohol intake, genetic susceptibility, environmental exposures, host effects, or a combination of influences. For patients with CLL, increased risk, per se, of second cancers were first reported about 30 years ago, with most elevated site-specific risk in this population likely not due to the late effects of cancer therapy. Since CLL is often an indolent malignancy, patients can live for many years and thus remain at long-term risk for second cancers. Since increased risk for second cancers are now well documented in many populations of cancer survivors, the research community has increasingly turned its attention to disease course and survival after a second cancer diagnosis. In this paper, Solomon and colleagues evaluate survival after a diagnosis of several common cancers in patients with CLL and compare this survival to that of patients without CLL. An underlying hypothesis is that the presence of CLL not only influences the risk of developing solid tumors, but may be associated with more aggressive behavior once they occur. If this hypothesis is true, it has implications for patient counseling and disease management. To accomplish this task, Solomon harnessed the power of the population-based cancer registries that report to the NCI SEER program. They evaluated over 2 million patients for survival after a diagnosis of a cancer of the breast, colon, kidney, lung, and colorectum. In doing this, they considered whether the patient had an antecedent diagnosis of CLL or not. Overall, among CLL patients, they identified 608 women who later developed breast cancer, 892 patients with colorectal cancer, over 1,200 men with prostate cancer, and almost 1,300 patients with lung cancer. They also identified a smaller number of patients with other cancers, such as kidney, pancreas, and ovary. These investigators then evaluated overall survival and cancer-specific survival using a Cox regression model on the age scale stratified by gender and adjusted for race and disease stage. The estimated relative risk from the model was then, in effect, a comparison of CLL patients to age, race, and gender-matched patients from the larger non-CLL population. After taking into account age, gender, and disease stage, Solomon found that the overall age-specific survival for CLL patients was significantly inferior for those who developed the cancer of the breast, colorectum, kidney, prostate, or lung. After patients with a CLL-related death were excluded, overall survival remained significantly shorter for patients with several of these cancers. These included the following sites and hazard ratios: breast cancer, 1.45, colorectum, 1.55, kidney, 1.34, lung, 1.15, and prostate, 1.40. The investigators next evaluated cancer-specific survival in a site-specific manner. For example, death due to breast cancer in a breast cancer patient, again after excluding patients with a CLL-related death. After accounting for age, gender, race, and disease stage, cancer-specific survival was significantly inferior for CLL patients who developed one of the following cancers: breast, colorectum, kidney, and lung, but not cancers of prostate, ovary, and pancreas. The hazard ratios in this regard were 1.41 for breast cancer, 1.64 for colorectum, 1.41 for kidney, and 1.13 for lung. What can we conclude from the study? These findings have important implications for patients with CLL. Cancers of the breast, lung, and colorectal sites represent the three most common cancers in U.S. women and two of the three most common cancers in U.S. men. These data suggest that CLL patients who develop these common cancers experience a more aggressive clinical course and are more likely to die from these cancers even after adjusting for age, race, and disease stage. Solomon and colleagues hypothesized that these unfavorable cancer-specific outcomes could be related to either more aggressive biologic characteristics of the second cancers in CLL patients or to less effective immune surveillance and control. The limitations of the SEER dataset precluded Solomon et al. From an in-depth probe of these various hypotheses. However, the study should also be viewed within the strengths of the SEER program. These investigators were able to evaluate a large number of patients in the general population and to adjust for age, gender, race, and disease stage, and to analyze both overall survival and cause-specific survival. The weaknesses of the study include limitations that are inherent to the SEER program. These include a lack of detailed data with regard to initial cancer therapy, other patient-specific factors that may affect prognosis, and a lack of data on subsequent courses of therapy. Moreover, for some of the cancers studied here in CLL patients, only relatively small numbers were identified, for example, 67 cases of ovarian cancer. Nonetheless, this study is important, not only in terms of CLL patients, but because it also now raises awareness of the importance of the further investigation of not only second cancer incidence, but also second cancer outcomes in all cancer survivors. First, it is important for clinicians to be aware that cancer survivors indeed may develop subsequent primary cancers. Even if risk per se for some of the more common cancers, for example, cancers of breast, colorectum, prostate, lung, are not elevated after a selected first primary cancer in large epidemiologic series, nonetheless, common cancers are common. at a minimum, all cancer survivors should be encouraged to follow guidelines for cancer screening recommended for the general population as recently reviewed in the October 20th issue of JACO. Identification of individuals at increased risk for additional primaries due to genetic predisposition, treatment, and other factors can also pinpoint patients who should have earlier and more frequent screening and or who might be candidates for prevention strategies. Further, it will also now be important to determine optimal management strategies for second cancers. Many times cancer survivors are limited in regard to treatment options since they have already received large amounts of other cytotoxic therapies, either radiation or chemotherapy. Further research is needed to understand how to optimize the treatment of not only those second cancers that indeed may reflect the carcinogenic effects of prior therapy, but also those second cancers which represent the operation of other factors as reviewed earlier in this podcast. The burgeoning number of second and higher order cancers also mandates that we further probe etiologic influences and genetic variants that heighten risk, and that we better define high-risk groups of patients for targeted preventive and interventional clinical strategies. This concludes this JACO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.